All right. I have about 6:33. So we're going to get started slowly for the last couple of stragglers that are coming in. Thank you all for joining. It's exciting to be out and talking to everyone. This is something I've done in the past, but it's been in person previously. So this is going to be the first one that I've actually done online only. So bear with me also, but I am excited that everyone's here. Throughout this discussion, I'm happy to have questions and answer those. I'm not so good at looking at the raising the hand and to potentially hear everyone. So if you have questions, please put it in the chat box. It should be an option maybe at the bottom of your screen. I have a couple people that's already made some comments, so thank you. But you'll put that in. I'll try to either answer them throughout or at the end of the discussion, okay? So tonight, the topic is one that is something I talk about commonly. I see lots of patients every day for this relating to men's health with erectile dysfunction. Just a little bit about me before I get any further into the topic. You're probably well aware, I work with the Urology group. I have been here since 2014. I have my patient office where I see patients in clinic is in Northern Kentucky. I do operate at the surgery center in Norwood, but for the most part, I see most of my patients in Kentucky. Originally from Southern Indiana, went to IU through medical school, and then went out to Virginia for my urology specific training. Since being here, I took over as chief medical officer in 2017, so I've been doing that also, which I enjoy very much. A lot of my practice is erectile dysfunction or topics related to men's health. I do other things, but it is certainly a topic that I enjoy speaking with people about. All right. All right, so to the topic. So erectile dysfunction, what is it, who has it, and what causes it? So we'll go through that individually. A lot of you often will obviously be interested in treatment options and want to know the specifics, but a lot of people want to know why they have it and why did it happen to them and why is it happening now? So basically, erectile dysfunction is the inability to achieve, so get an erection and then maintain it enough that you can have intercourse. How common is it? It's very common. It happens in about 1 in 5 American men that are over the age of 20. At some point during their life, they'll experience it. More than half of those men over the age of 40 have some degree of erectile dysfunction, whether it's minor or if it's significant. So that's many men in America. The number's about 39 million. As far as how an erection happens, so when a man is stimulated or aroused, basically what happens is there's a chemical reaction within the nerves within the penis and the pelvis. When those nerves fire and the chemicals are released, it talks to the arteries that basically have muscle lining them. When that happens, it relaxes the muscles of those arteries, blood flows in, and you get a full erect penis. While that's happening, at the same time, it basically pushes on the veins of the penis so that the blood can't flow out. So it kind of traps it in, and that's what allows you to maintain that erection. So you can see the picture on the right with the flaccid penis as far as there's not much blood flow in. When things are aroused and the nerves are firing and the blood flow is flowing in and it's being blocked off, that's when you have a successful erection. As far as what can cause it, there are several things. Most of these options or causes relate to vessel disease that can happen throughout the body, specifically around the penis, diabetes, and we'll talk the specifics of that, And also medications. There are some medications that can be given that can either affect blood flow patterns, your blood pressure, some anxiety or depression pills. There's several that have that unfortunate side effect that can affect the ability or to get an erection or to maintain it. It also, for some of you, may be related to prostate cancer. If you're unfortunate and have that diagnosis and had treatment, the treatment itself, whether it's surgery or radiation, could be causing that for you. And we'll go through some of the specifics of that. Diabetes specifically, we'll go over that first. So I'm sure you know someone that has diabetes. You may unfortunately have it, or your partner has it, or someone in your family or neighbors. It's very, very common. So many years ago, they determined 15 million men, specifically in the US, had diabetes. For those that have diabetes, erectile dysfunction can occur about 10 to 15 years earlier than someone that does not, just simply because of the pathophysiology relating to erectile dysfunction and what it actually does to the vessels. And we'll get into that too. The other part of that is when we treat someone that has diabetes and erectile dysfunction relating to the diabetes, the medications tend to work a little less with it. So that's something also to think about. 1 in 2 men with diabetes will have some type of sexual troubles that's related to the diabetes specifically. In those men, ED tends to be more severe and is associated with a poor quality of life relating to that. In some patients, ED can be the presenting symptoms of diabetes. ED can be the presenting symptoms of diabetes. Unfortunately, I've seen it enough in my office where erections was the concern. That was the topic that we were discussing. And there's symptoms that indicate that diabetes may be in the picture, or that we see sugar in the urine with a high glucose. And I'm having to send the patient to the primary care provider because that was the warning sign that something was going on that needs to be addressed. All right. As far as diabetes goes, the diabetes specifically causes a high level of glucose or sugar in the bloodstream. In doing that, it can cause damage to the blood vessels, but also specifically the nerves. They tend not to work as well because, as we mentioned at the beginning, the nerves are what cause the start of the process of getting an erection that allow the blood flow to increase. If those nerves aren't working, then your erection is not going to occur. About 60 to 70% of people with diabetes have nerve damage. You'll hear some people call that neuropathy. A lot of people have lower extremity or leg nephropathy, but the same thing can happen around the bladder and the prostate, and specifically to the penis, which can affect erections. Diabetes can also increase a process called endothelial dysfunction. That's just a fancy term to basically say it can start causing damage to the lining of the vessels, the blood vessels that cause blood flow or allow blood flow into the penis. If you can think of a pipe with water flowing through, when you start getting sludge that slows down the flow within a pipe, the same thing can happen in the vessels, and that's what this does, and diabetes increases the rate of that happening. Oral medications that we prescribe, such as Viagra, Levitra, Cialis, all those medicines, they require some kind of sexual stimulation, basically making the nerves fire, that also then increases the blood flow in, that process we talked about at the beginning. So if the nerves are still damaged, that basically precludes or keeps the oral medication from working as well. So they just won't be quite as effective, unfortunately. All right, so for those that are fortunate not to have diabetes, but may have some concerns for heart disease, either you've have been given that diagnosis, or you have it in your family history, so you're concerned that it may affect you at some time. Let's talk about that topic. One thing that is common is I'll have a young guy in his 40s come in with erectile dysfunction, and we're talking about things, and he otherwise is a healthy guy. it really gets me very concerned because it means that we need to start thinking in a bigger picture. Of course, we can treat the erectile dysfunction, but I want to make sure that the patient, you and I, are on the same page, and that the primary care physician knows what's going on, because it could be an early warning sign that there's more serious things going on, specifically in your heart. It can be an indicator, ED can be an indicator that you have coronary artery disease and poor blood flow around the heart. ED in itself is a risk factor for future cardiovascular events. What does that mean? We're talking about heart attacks, strokes, things like that. It can also be correlated with the amount of heart disease you have. So the worse your erectile dysfunction is, the more concerning it is that you have serious heart disease. Erectile dysfunction sometimes will come before any warning signs, such as chest pain, shortness of breath, things like that. And it is usually present before you would have those heart symptoms in about 70% of patients. So it's very important to pay attention to that. I try to talk to anyone that's coming in my office that doesn't have heart disease, diagnose for them that, hey, we may need to consider this, and you need to open the conversation up to your family doctor. Symptoms of heart disease often occur about 2 to 3 years after erectile dysfunction occurs. And within 3 to 5 years of erectile dysfunction being noticed, often a heart attack could occur. Okay, so things to think about. Talking about blood flow specifically, arteries supply the blood flow to the penis. Those are much, much smaller than those that are elsewhere in your body, specifically that supply your heart, your brain, and your lower extremities and legs. For that reason, if you can imagine, a smaller pipe, or in plumbing, would get filled with sludge a lot sooner than a large pipe would. The vessels work the same. So you take a small vessel within the penis, it's going to get a little sludge in it, or plaque. Some people use that as a term, and it can clog it up very quickly, long before it would in a larger vessel, such as that you see in the middle of the screen, that would affect your heart. Or internal carotid artery is what's kind of going in your neck that helps supply the blood flow to your brain. So if that were to get clogged, you can get a stroke, or a TIA, which is a very short-acting stroke symptom that resolves on its own. And then the biggest vessels are those that feed the blood flow to your lower extremities. Equal amounts of plaque that are applied to the inner linings of these vessels. At 50% of obstruction, the penile artery may cause symptoms of erectile dysfunction. So in other words, all it has to be is 50% obstructed, or halfway blocked, for it to cause symptoms that would affect erectile dysfunction. So what can you do specifically related to heart health, diabetes health, to reduce the risk of erectile dysfunction? Basically, anything that's heart healthy is good for erections. That includes healthy diet, exercise, physical activity daily. If you're considered a little bit overweight or a lot overweight, then weight loss would help you. If you're a smoker, that significantly affects blood vessels and blood flow, and heart health in general. So quitting smoking would help. And also stress reduction. Stress has a great effect on our body in negative ways. So that is definitely something that I think most of us kind of overlook, because it's not the eating, drinking, exercise, things like that, but definitely can have ill effects on you. All right. Now, often I get questions about low testosterone, or how does that play a role, if I get treated with testosterone, will my erectile dysfunction go away? And it's a great question. As men age, testosterone tends to start lowering and decreasing with time. It's different in everybody, but it definitely can play a role, and it's something to think about. So hypogonadism, or low testosterone, or low T, these are all terms that you will hear get thrown around in the media and press, and what people are talking about. It happens basically when the testosterone in your body starts to decrease. It basically can result in increase in sexual dysfunction. It can change your body composition, and generally just a decreased feeling of well-being. So how common is it? About 4 in 10 men over the age of 45 may have low testosterone. As I mentioned earlier, it becomes more common as age increases. Low testosterone is common in men who are overweight, diabetic, have high cholesterol or high blood pressure. And all those things I just mentioned increases your risk of having low testosterone. So what are symptoms of low testosterone? There are several. The things that people probably complain about the most is fatigue or loss of energy. If that's something that you seem to struggle with on a daily, from day to day, that's something you may want to consider. Also, you may notice a decrease in muscle mass or strength. Maybe you're working out just as much as you ever did, but you feel like you're struggling to really make any gains. Or is it just that you feel like you've maybe even lost weight, you don't work out very much, but you can just tell that you've lost a little bit of that strength with day-to-day activities. You may notice increase in body fat because the body fat does tend to replace the muscle mass lost. You may notice loss of hair, especially in other different parts of the body, not necessarily just on your head. And you may notice that you just don't need to shave as much as you used to. That could be a sign. You may notice decreased physical performance or work performance. Maybe at work you struggle a little bit more. You could have some hot flashes or sweats, just like women do with menopause. You could have that in the more extreme situations. It's a little less common. You may notice a little bit of feeling sad or blue or slight depression symptoms, maybe a little less motivation to do anything or enthusiasm or drive to get things done. May also have a little less self-confidence. That kind of goes with not feeling so good. Some people just notice that tasks are a little more difficult, and maybe not physically, but the ability to concentrate, stay on task, maybe memory can be affected. And for some, the biggest thing that they may notice is a decreased libido or interest in sex, along with erectile dysfunction. If you are diagnosed with low testosterone, and we usually do that by checking blood work, we can check for your total testosterone level. Sometimes we check what's called a free testosterone. It's sometimes better to do it in the morning, but that's not always the case that it has to be that way. Basically, the options for that would be a testosterone replacement. That can be done transdermal, so basically something you put on your skin. Often gels, patches are common. There is some nasal spray options out there. There's definitely injection therapy. There are some pellets that go under the skin. There's several different options depending on the person and preference, and some other outside things that we think about. There's no real good pill for replacement at this point. But there are some oral medications that can alter testosterone that we do sometimes use. All right. So for those of you that do have a prostate cancer diagnosis or have been treated with radiation or surgery of some type, erectile dysfunction is something that you may be struggling with. Now, everyone wonders kind of why is that? If you have treatment for prostate cancer, is it the cancer? Is it the surgery specifically? Is it the healing? What is it? So we'll just go through that real quick. Basically, you see this picture on the right. There's a bladder. Next to that is a prostate. As the urine goes out through the prostate, it goes out the urethra as you urinate. You can see that there are several nerves that sit right between the prostate and bladder. They run alongside the lateral sides of the prostate. So whenever you are having a prostatectomy done, which means removal of the prostate, it has to have an incision that's done between prostate, bladder, and prostate and the rest of the urethra, and then off the sides to get it away from the rest of the tissue. It used to be that we did not do nerve sparing procedures. And so those nerves would be lost. Several years ago, we realized that there were things that we could do to save those nerves as much as possible and maintain better erections afterwards, and also continence and ability to control your urine. So there's procedures called nerve sparing surgeries. When we do that, we still are touching the nerves and moving them and stretching them and doing slight damage to them. Now, the whole idea is that the nerves will heal and come back and the erections will be maintained or improve over time. But it is very common, at least at the beginning, that erections are affected because, as you can see, it's really hard to totally avoid those. So overall, erectile dysfunction affects 25 to 75% of men after treatment. It can happen as a result of prostate cancer surgery, whether it's robotic or not. We've gotten much better with the robot, but still in those men, 10 to 46% of men at 1 year still have some ED. Sexual dysfunction after radiation affects about 50% of men. Even though it's not surgery, you are still having something done to the tissue, just like it's supposed to kill the cancer, it can do some damage to those nerves. So even though it's not a surgical treatment, it is still something that could be a cause. At the same time, it happens at a time in life for most people that they're noticing some decline in erectile function as it is. So it gets very noticed as treatment occurs. This is Peyronie's disease. So Peyronie's disease is somewhat a new topic. It's not that it's a new medical condition at all, but you see it much more in mainstream and marketing, specifically related to a certain treatment that's out there that's done a lot of marketing to people so that they understand that this is an illness or condition that is common. So Peyronie's disease is basically a curvature of an erection. So you may not notice anything when the penis is flaccid, but when you get the erection, you'll notice a curve one direction or the other. It could be down, up, left, or right, or a combination with kind of like a twist. I mean, it's just different for everybody. What happens is you get basically a scar in the lining of the penis. So not the skin, but then the layer deeper that covers the erectile bodies. And if you get a scar or plaque, there's different terms that people use, it basically will take over that area. And what happens is if you have a scar in an area that stretches, as you know, usually most people get some increased length and girth with a full erection. That tissue has to stretch on the inside. That's why it works so well. But if you were to get a scar, it becomes very, very stiff and rigid in that area specifically, and it doesn't stretch. So it kind of has this rubber band effect. Excuse me. When it does that and someone gets an erection, it stretches everywhere else but right there, and you'll notice a curve. Some people may not notice a curve, but they have a bump or a hard spot that they can feel. If it doesn't cause a curve, then there's really no issues, but that could be what it is. So that's something you can see your urologist about and ask them. But it's definitely not anything that's dangerous otherwise. People get very worried about the name Peyronie's disease. I wouldn't really necessarily call it a disease. It's more just a condition that some people have. It can affect the ability sometimes for an erection to happen well, just because we talked about how blood flow comes in and it has to fill and close off the veins that let the blood flow out. Sometimes it can mess with the dynamics of that working, so you may not be able to maintain an erection quite as well. Obviously, if someone has a curve that's bothersome to some, other people, they don't mind so much, but that's an individual issue. So some people have stress or anxiety relating to it. It also can cause problems within the relationship. The curve itself can occasionally cause pain for the partner, just because of the curvature, and the angles related to sex can be uncomfortable. So signs and symptom may appear suddenly. I have many people that will come to me and they say, I just woke up this way. It wasn't curved yesterday, but it is today. So it can happen quite suddenly. Some people will notice just a bump, and that bump slowly over time turns into a curve. I think we talked about most of this. Some people won't notice a curve, but will notice a lump or bump or band of tissue. Some people will just notice almost like an hourglass where it gets narrow with a full erection in a very specific area, but there is no curve. All those things could be related to Peyronie's disease, and erectile dysfunction can occur to that. Because that tissue can't stretch in that area, some people will notice a shortening of the penis or at least shortening of an erection. And because it is somewhat of a scar, which is an inflammatory reaction, it can be quite tender, especially with getting an erection. The pain almost always goes away. It just takes time for some people. Maybe it could be a couple days. For some, I've seen it last a year and a half, and it's taken a long time, but it does usually always go away. If you have symptoms that are significant or they worsen over time, you should certainly talk to your physician about it. Most urologists are fairly well versed in Peyronie's disease, but there's usually a specialist, at least in most of our offices, that can provide treatment, or they know who can and get you there. Options would be a medication. There's actually no pill or cream. I wish there was. It'd be a lot easier. That works well. There's nothing that's recommended in that category, but there is the medication that is injected into that scar or plaque that works on breaking it down. It's called collagenase as the actual enzyme that works, but the product is called Xiaflex, so you'll see that around. That's used commonly for non-surgical fixes for Peyronie's. You could have a surgery that basically plicates or shortens the other side. Basically what it does is you're trying to, if you have a curvature on a penis with a scar on this side, we're trying to go in and kind of fixate or plicate this side or dart it so that it straightens it out. Sometimes if the curvature is too great, we will take out the scar and put in a graft. That always theoretically sounds like a good option, but that does have more side effects, especially related to erectile dysfunction, so we don't do it as commonly. And then if that doesn't work or you don't desire those treatments, especially for anyone that already has some erectile dysfunction, then we often will use a penile implant, which we'll get into the more details shortly. But that will kind of take care of both problems. So it's a common choice for a lot of my patients that have some erectile dysfunction and also a curve that they are not pleased with. All right, so we bring up treatment options, which I know most of you are more interested in. And I see a lot of questions coming through, so I'm going to try to answer them as I go. But at the end, again, I'll go through and make sure I didn't miss any specifically. So we're going to go through this whole menu of options from oral medications, injections into the penis, surgical implants for prosthesis, vacuum erection devices that you can use on the outside, and then suppositories on the inside. All right. So most people have heard of Viagra and Cialis. We have Levitra, we have Stendra. Recently, the generic options have come out, such as sildenafil and tadalafil. They're the same things, it's just generic options. So how do they work? They're called PDE5 inhibitors. And basically what they do is they increase blood flow to the penis. We talked about how important that was. They can hopefully improve the ability for the erection to occur, and also with that increased blood flow, help maintain it longer. It still requires stimulation. So just because you take a Viagra doesn't mean you're just spontaneously going to get an erection. You still need foreplay or something that's going to stimulate that for you. Most of them usually are, if you take them within an hour, they'll work. Some of them are closer to 15 to 30 minutes. Some of them do take that full hour. On average, they probably work for about 4 hours. Cialis or tadalafil is the exception to that. I tell people it works for about a day and a half. It has a longer half-life. They should not be taken more than once a day, any of them. And some of them, specifically sildenafil or Viagra, are significantly affected by eating or drinking with it. So it really needs to be on an empty stomach. That's probably the first thing I tell, goodness, most of my patients is they come in, they say Viagra either used to help and doesn't work now, or it just never worked. And I immediately will ask, did you take it on an empty stomach? So specifically for that medicine, I tell people take at least 30 minutes before a meal or 2 hours after. Um, for it to work, you really need the absorption from the stomach. Many of those medications you can crush. They don't taste good, but you can take the medication and kind of get the effect a little bit quicker, and it works better. Cialis or tadalafil is on the other end of the spectrum. You can take it with food. It doesn't matter. And it's going to work longer, so you can kind of think about it a little less or have to plan a little less with it. They work about 50 to 85% of cases of patients taking them. I definitely recommend people to try it first before other options. Almost half the men, though, with ED after prostate surgery will try it and eventually give up on it because either they don't like the side effects, they don't like having to take it, or it just doesn't work any longer. With men, specifically with diabetes, because of the same reasons we brought up earlier with nerve damage and blood flow issues, it's more likely for the medication to not work and then move on to other treatment options. Common side effects for the medicine would be headache, flushing, kind of feeling like you're congested or a stuffy nose, sometimes a little nausea. I would say probably Viagra or sildenafil is the biggest cause of those side effects, probably more than the other pills. Things to think about, if you have heart disease or had a prior heart attack, you definitely want to mention that to your urologist or provider that's providing the medication, especially if you have chest pain and to use like sublingual nitrates. That is something you absolutely cannot take with these PDE5 oral medications, PDE5 inhibitors that are the pills. With alpha blockers, which are like Flomax, tamsulosin, Rapaflo, some medications that you take to help urinate are commonly given for that. Those can cause a little bit of lightheadedness, so I'd never start both medications at the same time. Most of my patients do well on both, but I'm just cautious starting to take one first and getting used to it before you add the other medicines such as Viagra or Cialis. As we mentioned before, if you have any heart problems, high blood pressure, prior strokes, liver, kidney problems, you need to mention that to your physician about these medications before starting. All right, so a vacuum erection device, or what we refer to as a VED. Basically, this is what I call kind of a canister. Usually it's a plastic tube. You put it over the penis, kind of creates a suction, so that can either be done by kind of hand power or battery operated. It pulls the air out, which creates that vacuum effect, and it pulls blood flow in. It works, but to basically keep the erection maintained when you take the device off, you do have to put something around like a band or ring at the base of the penis to keep the blood flow in. Otherwise the blood flow will go out. Probably the biggest complaint is for some people, this is really hard to use. It's a little cumbersome, or it's hard to just maintain and keep that full erection during the process. Patient satisfaction rates range from about 68 to 80%. I feel like in my specific patient population, it's probably less than that. I just have not too many patients. They may try it, it may work, but eventually they kind of move on to other treatment options. 86% of patients decide to go on to other options, which I would agree with. Most common side effects of this, if you can imagine, when you put a ring around the base, it's going to block the ejaculation fluid from coming out. I do recommend if you're going to use this, you want a medical grade one. It will limit the amount of pressure or vacuum that is put on the skin and the tissue, because if it is too strong, you can get significant bruising and swelling afterwards or pain. And the medical grade ones can still happen some mild bruising, but it is much more limited with this. So as I said, it can cause a little discomfort. And when you block the flow to the penis, you will notice that it is actually in a cold erection. Some partners may complain about this a little bit because you're not getting active flow. It is cooler to the touch. Most common reasons for discontinuing, just as I mentioned earlier, difficulty maintaining the rigidity during intercourse, just hard kind of using it, again, cumbersome, the bruising and the lack of spontaneity, that you kind of have to get it out and use it beforehand. All right, so urethral suppository. This specifically is something called Muse. It's a small, I kind of call it like a rice pellet that you put in the end of the urethra inside. You pee first, and then you put this in. You leave it in, and usually you start noticing some improvement in erection about 5 to 10 minutes. Medicine itself does have to be refrigerated. Basically, it's similar medication to something that we're going to talk about in a minute. As far as it's an injection, success rates are about 40 to 65% of people, and about half of men don't continue to therapy after 6 to 8 months. And as I mentioned, I have very few, probably almost no patients on this, just because they tend not to like it for different reasons. That being, it can cause some achiness in the penis or scrotum in general. You can have some burning when you pee. Can decrease blood pressure. It's a little less common, but it could happen, just as dizziness could occur. I also have had some complaints before in the past that for their partner, it could cause some vaginal irritation, things like that with the use. So biggest reasons why it's discontinued would be they just can't maintain those good erections or the discomfort associated with it. Intracavernous injection therapy. Some people call this ICI. There's several different options. There's 3 different medications that can work to do this. Sometimes you'll get one medication. Other times it's a mix of 2 or 3 of them put together. Basically, this is something that you would inject yourself, or your partner could inject it into the side of the penis, right into the erectile bodies. It takes about 5 to 20 minutes. I'd say the average is 10 minutes or so for the medication to start working. It's very different than the oral medication where I said you need to have stimulation. This is not the case. Once you give this medication, if you have the dose right, you're going to get an erection within 10 to 15 minutes or so. I always like to tell everyone that even if grandma walks in and sits down next to you, you're going to maintain that erection whether you want to or not, despite what the situation holds for you. So it is different. About 60% of patients are satisfied with using it and will continue using it. But about long term, when they looked at a study of over 250 men, only about 20% continued to use the therapy, even if it was working long term. So different studies obviously give us different answers. I will tell you, a lot of my patients are happy with it for a while. It tends to be 2 boats. Either they come in and we get the dose correct, it works well, but after 1 or 2 times they're like, I can't do this. Usually it's not from a pain perspective, just it's the whole idea of it, having to do it, the fact that they got to plan ahead to get the medication, all those things. And then the other ones are, I'm just tired of doing the injection beforehand. I don't want to do it anymore. It can cause a little discomfort for some. Over time, if you inject, especially in a similar spot over and over again, just like you can get a scar anywhere else in your body, you can form a scar there. So we do ask people to alternate sides as you give it to yourself. If we don't have the dosing correct and it's too high, you can get a priapism or an erection that lasts greater than 4 hours or with pain. I know you've probably heard of that from TV commercials, and although some people would say there's no way that's a problem, it is a problem when it's you and the erection won't go away and you have discomfort and you're going into the emergency room, because that is what the outcome is if we don't have it dosed right, or you are unfortunate and have a priapism. Some people get a little bit of bruising or blood collection under the skin, especially if you hit like a little vessel. It usually doesn't cause any damage or anything like that, but can be irritating. So why would people stop using it after they start? As I mentioned earlier, they're just not happy with the quality of the erections. It may be the discomfort or pain, or they just don't want to do the injections anymore. So penile implant, that's our next option. So this is a surgical option that we often will talk about. And so how does it work? You basically have 2 cylinders that are inflatable. They are implanted into the main part of the penis. As I mentioned earlier, you saw those 2 circles that fill with blood. So they're basically two cylinders that sit in the penis in the natural body, and these inflatable cylinders take the spot of those two. A pump sits just inside the scrotum next to the testicles, and then a reservoir of fluid or saline sits in the lower abdomen or pelvis typically. So there's those three components in a typical penile prosthesis. So how you make it work is that you would squeeze the pump that sits in the scrotum, and it will cycle the fluid that sits in the reservoir in the pelvis, and it cycles it and puts it into the inflatable prosthesis or cylinders. Once you have an erection that you're satisfied with and you're done, you would then click, press a button that sits on top of the pump, and it allows the fluid to cycle out and back into the reservoir. Basically, this is something that's completely internal. You cannot see it on the outside of the body. When you're flaccid or it's not inflated, it looks like a normal penis. Looks like a normal erection when it is inflated. The only way anyone would know is if they did actual like if I was doing an exam on someone, I could tell, but just by looking, no one would know. 98% of patients report that the erections are excellent or satisfactory. So most people are very happy with it once it's done. At 7 years after having the procedure done, 94% of the people are still using it and have not had to have a repeat surgery. Most common side effects include discomfort after surgery. This is a device, so it can malfunction. Occasionally you could have autoinflation where it pumps up on itself whenever you sit oddly. Things have been done to the device to prevent that from happening, so it is fairly rare. And because it is a foreign body, there is always a chance of infection. If it gets infected, it typically does have to be removed. So let's go through a video and watch that, and then we'll get a little more information. So, as you can see here, this is where the pump sits next to the testicle. And as you pump it up, it cycles the fluid out of the reservoir and up and into the cylinders. You can see that the reservoir kind of emptied. And then now that he's pressing the button, it is allowing the fluid to reverse itself, leave the inflated prosthesis and into the reservoir. Okay. So a couple things. I think people like to know the details of this. These prostheses have been around for many, many, many years. They've been improved upon slightly, but they're not anything new. I think sometimes I mention it to a patient and they can't believe it exists, but this is something that's been around for over 40 years at this point. It's a definite permanent solution to erectile dysfunction. It's not anything where you have to take a pill or worry about side effects once everything is healed and ready to use. You don't have to worry about injecting a medication or running out of it, or a medication no longer works, or it has to be refrigerated. When you travel, you're not having to take anything with you. So from that standpoint, it allows for the most natural situation when you're with your partner. Erections don't have a time limit on them. You can leave the pump inflated for as long as you like, and then deflate it when you're done, so you don't have to worry about a medication running out or anything like that. Everything's on the inside. So again, as I mentioned earlier, no one really knows you have it. Patients, partners are highly satisfied. It does not do anything to the ejaculation or ability to have an orgasm. And I tell people that, I remind them that frequently, because if you come in with a problem with orgasm or ejaculation, this will not fix it. But it also is not going to take it away if that part's working fine for you. Interestingly, your ability to have orgasm or ejaculation really has nothing to do with the physiologic things that blood flow is involved with. So as I mentioned earlier, you need the nerves to work and the blood flow to work. That may not work at all for you, but you can still have the ability to have an orgasm or an ejaculation. So they're really two different things. So the surgery won't affect that at all. As I mentioned, they've been around a long time. Nearly 500,000 patients have been treated with a penile implant. So they are fairly common that we do them. A lot of people ask, what is it like? What's the process? When someone comes into the office, we talk about this option. If that was what they chose to do, we would get approval by insurance. It typically is covered by most insurances, not all of them, but most of them. When the surgery happens, it's typically outpatient. Most of these are done with a single incision. You go home, you're sore for a couple. I tell people, you're sore for about 2 weeks or so. I limit people's lifting for about 4 weeks. And then you're able to start using it in about 5 to 6 weeks or so, depending on how well you heal. So, you're sore and it takes a little while to get over that. It is a surgery, so there's a little more work on your part compared to taking a pill or an injection. But once you're healed and over that, it is something that you don't have to think so much about. So what are the risks with that? So it's a surgery just like any other. You will have an anesthesia with it. So this is not done awake. So there's the natural risks that go along with the anesthesia. Not everyone is a surgical candidate. So we go through that with you, obviously, to talk about the details of your health history and what you've been involved with before. As far as risks, though, this kind of is a permanent answer, as I mentioned that earlier, but that also means that we can't go back to other treatment options. So once the penile prosthesis is in place, if you were to have it removed, you can't go back to injection therapy or oral medications because it kind of makes that part of the corporal bodies that I mentioned that fill with blood no longer function. It is a device with moving parts. So it can have a mechanical failure or not work. If something doesn't work, we typically have to remove it and put in a new prosthesis. So occasionally you may need a revision surgery, especially if you're younger when you have the first one put in. If it needs to be removed and replaced, there can be sometimes scar tissue. So there occasionally will be complaint that it seems a little shorter or more curved or scarred. I get concerned more of this if someone has an infection, it has to be removed. With the idea when we put another one in later, then that could happen, but it doesn't happen too often. Postoperative pain, obviously it's surgery in a very tender area. I'm always surprised how well people do with this, but it causes, some discomfort. You're not wanting to go out and jump around or do any activity for the first week or two, certainly, because you're pretty sore. Men with diabetes and spinal cord injury, and any sores have an increased risk of infection. Diabetes leads to poor wound healing. So we always have to have that discussion, but I will commonly put these in diabetic patients. Spinal cord injuries, same thing, and sores. So we just don't want you to have any infection risk currently in your body when we do the surgery to minimize the actual device getting infected. All right, so what did we talk about today? ED, erectile dysfunction, is very, very common. It's associated with many medical problems that are common to us, unfortunately, including heart disease, diabetes, low testosterone. There are lots of treatment options. I give everybody kind of the menu of options from the easiest to hardest. So everyone, what's right for one person isn't right for the next. And some people start at the beginning and work their way through to the end option, and others jump around and decide that maybe injections aren't right for them because they don't like needles, and that's perfectly appropriate. It's very, very important to talk to your partner, especially if you have a partner at a time. If you're married, you're not married. Sometimes people think this is going to be the solution to everything, and it may not be that erections are the problem. There may be something else going on that you need to be very open and upfront. Surprising your spouse or partner with the penile prosthesis or the surgery, the pump, on Valentine's Day may not be the best way to go. It just depends on your relationship. So just be very open with this conversation. Often I encourage my patients to bring in their partner with them, because also you're telling a lot of information. So it's good for them, for two people to hear it, and also for them to understand it. Otherwise, sometimes, the wires get crossed and the meaning may seem a little different to your partner. Penile surgery, or the penile implants that we discuss, is a permanent option. Once you do that, you shouldn't have to consider any of those other options that we discussed that leads up to it. And then what I really, really encourage you to do is to talk to your urologist if you already have one. If they don't specifically treat very much erectile dysfunction, or they don't do the surgery, then I am sure, at least within our group, they know someone in their office or someone within the group that they can refer you to that does a good volume of these and knows what they're talking about. But the biggest thing is to talk to your provider. If you're just talking to your family doctor, then they're going to know a urologist they can get you into. If you look at this slide, it has edcure.org. It is a very good website with lots of resources. It also will give a listing of a urologist that does the surgery, so they should be well versed in erectile dysfunction treatment options altogether that would be very good for you. Okay. I'm going to go through questions that people have had. I think a lot of the time, most of these are answered, but I'm going to make sure I did go through them all. Otherwise, if you are running out of time, I appreciate you coming and joining me from home or wherever you are and listening. But I'll go on to questions. All right. So how much does a penile